So I've got a great interview for you today. And if you are looking for information on the menopause space, on HRT, this is an interview you have to listen to. So Kristin Johnson and Maria Klaps wrote this book called The Great Menopause Myth. I was fortunate to get an early copy and read it several months ago, actually. And it is a fantastic book that really goes into a lot of the lifestyle things that I was so impressed with the way that they wrote it, and really jives with just about everything that I believe as far as how to look at health span in perimenopause and postmenopausal women. It just is so good. They also go a lot in this book into HRT, hormone replacement therapy. They talk about several different options, several different forms, varieties, their clinical experience, as well as kind of a deep dive into the literature. And so I really appreciate the objectivity they had in that book. And I wanted to bring them on the show to talk about their experience because as a non-provider, as a non-physician, they are experiencing what so many other physicians are doing, and then the ramifications or the benefits potentially of those different therapies. So we get into in this video today, this interview, we get into what is wrong with some of the traditional models of hormone replacement therapy. What are some things that you should definitely avoid? So you're going to want to know if you're on some of those. But then we talk about some of the things that are not as well known. We talk about cycling progesterone. We talk about true physiologic hormone replacement therapy. We talk about the potential benefits. We talk about the benefits for bone, but also for the heart and the brain and other things. So if you're interested in this space, this is an interview you have to listen to because you probably haven't heard some of these concepts yet. All right. So Maria and Kristin, thank you so much for joining me today. There are so many things that we could talk about, but I really want to dig into some of the stuff in your book that is really going to, I think, ring true with my audience, specifically around hormones, some varieties of different things that you've seen in your kind of clinical practice, the way that you're working with women. And then maybe we'll have some time to get into some lifestyle stuff because there's a lot of stuff in your book that just I really enjoyed reading. But let's just start with this. If you could just give us a little background around sort of, how you guys got into the space around working with women and really what your focus is so that we can set the stage for this talk.
Yeah, as is probably most people who've gotten into this, it comes out of really a need to kind of solve one's own issues. And that's because, when I was perimenopausal around the age of 43, I did see what I thought was a really good doctor in Manhattan. And it wasn't a terrible experience. But it did lack education. And he did throw at me way too many supplements. He actually did prescribe HRT for me, bioidentical HRT at that point. And I was not against that. In fact, I now say in retrospect, had I been on HRT since I probably should have been on it since age 45, full HRT. But I didn't continue the HRT that he gave me because I had no education. I mean, it was this wonderful kind of well-oiled machine in Manhattan. You would think that there would be more of an education component, and there wasn't. So I probably quit after about 6 to maybe 8 months on it. But I did say that, oh, wow, there does have to be something better out there. And I just knew that I needed to learn. And it was at that point that I just pursued more education and mentorship. So that is how I got into it.
Great. And then how did the connection between you and Kristin happen?
Well, so I had a similar experience as Maria in terms of timing. Life kind of shook right around 43 for me. I didn't know that it was my hormones. My mom was menopausal due to surgery at 32. So I didn't live through it, didn't have a benchmark for what her kind of timing was going to be. And I had the opposite of Maria. I was completely gaslit. I was told I was too young. There was no way it could be my hormones. Kind of made to think that I must be doing something wrong. I begged to get tested for mold, Lyme, you name it. I knew something was wrong. And so similar to Maria, that motivated me to go get education. Ended up, finding Maria because we were both utilizing a certain type of testing, but she had been using it a lot longer and she had a instructional course for practitioners. And so I took that course. And then the two of us kind of just hit it off. And it was one of these things where it was like, oh, I kind of like her and working with her. And then she had a little bit of a program that I started kind of helping with and still running my own practice. And then we were both like, gosh, gee, this is a lot more fun to do together. So we both kind of let our individual practices go by the wayside and combined forces legally, which was great. And, we're going on, I think we're 6 years in and going on 7. So we're, been doing this a long time together. And we've both spent a lot of time together with physicians. And that's the thing that I think a lot of people don't understand, is that there is a huge menagerie of HRT providers in this country. Some are better than others. All bring different kind of viewpoints and practice approaches. And so we've spent a lot of time kind of learning from them, training with them, and now have built a referral practice based on sort of our observations as to what has worked with whom and how to best serve women.
Yeah. Yeah, and that's such an awesome perspective, because I spend a lot of time, and I'm sure you do too, on social media, and we hear doctors who are advocates for hormones. Some doctors are not advocates for hormones and advocates for other pharmaceuticals, or just suck it up. You don't need any of it. All of the different approaches from a doctor's perspective can be just so hard lined, and I feel like people will kind of fall into whomever fits their kind of mentality. And then
Or
they're kind of stuck
biases.
with, yeah, sure. And I think Instagram actually does that for us, right? So like we get sort of algorithmed into certain individuals. And then they're sort of stuck with those recommendations. But what I love about, where you guys are coming from is that you have seen a huge spectrum. And that's what I want to get into today, because you've seen people come from all kinds of different backgrounds to work with you. Before we get into sort of what those different varieties are, give us a little sense of, like, when you work with someone, what does that look like? What is is it like a program, a one-on-one coaching? What are you guys actually doing with clients?
Yeah, right now we have a 6-month program. We are actually going to expand what we do, but what we've done for about 6 years is a 6-month program where the primary role of the program is to make women a good host for hormone replacement therapy. And that's because we all know if someone comes in metabolically unhealthy, obese, inflamed, she's not going to have a good experience with that HRT. Okay. So
Yeah.
we make her a good host, and you don't even have to be all those things. You could have really, you can be non-obese, but still metabolically unhealthy. You can be, non-obese and still have really poor gut health. So we focus on gut health, nutrition, fitness. We have a fitness certified strength and conditioning specialist on staff. And we also, we help women improve their nutrition, because we find most women at this stage of life are, they're trying to shrink themselves, right? Because a lot of them have put on, body weight and body fat, and they're trying to shrink themselves, and they're usually going about it in a very punitive way. So all that. And then a huge component kind of comes towards the end of the 6 months, is that we educate them, like, what's out there for you. And we do kind of like an overview A to Z. And I would say it's more than an overview. We go pretty deep on what can achieve what, which types of HRT can achieve what.
And I think what we do in the very, very beginning is just kind of help a woman understand what's been happening, right? Because most of them, even if they know it's hormones, they don't quite understand why, because we've been told that hormones are just about menstruation and fertility. And if you've got a 56-year-old woman, she A, wants to ditch her menstrual cycle, and B, isn't really too concerned about fertility any longer. So getting women to understand the role that the hormones played in their body all those years is really crucial to them being understand why then HRT may or may not be a tool they want to add to their toolbox. And so we do start out with kind of this basic, here's the imperatives of hormones in a female body your entire life. Here's what happens when we lose them. Oh, by the way, you've got a lot of levers, like Maria described, all that lifestyle stuff. And then we flip into but even the best lifestyle isn't usually enough to mitigate bone loss, to mitigate cardiovascular disease risk, to, that stuff. So then we bring into the HRT discussion.
Yeah. So I had I had a substitute patient slot this morning, and this is a recording day, so I don't usually see patients, but we're just trying to get some people in. And so I just saw a patient, and it was such a great example of the same thing. Now, this is through the lens of osteoporosis, but she was frustrated because she's been with us for about 18 months, and she just had her first repeat DEXA. And it was, probably marginally better, but essentially the same clinically, right? So it's within the margin of error. And she was, justifiably upset. She feels like she's been doing a lot of stuff. but she's in that window of the 10 to 20 years out from menopause. And she was so scared to go on hormone replacement therapy, even though she has zero risk factors outside of her specific age. And we had made the recommendation to do so, but she wanted to wait and see how she could do without it. And so we, she stabilized her bone, that's still a win. That's good. That means you're doing good stuff. But the power of HRT then is that we spent half of the time together just talking about, these are the risks, these are the benefits. This is what I would recommend that you do. And so now she's going to go on that journey, and I'm so excited for her because I think it's going to be night and day, the difference between what she was able to do without it and what she's able to do with it.
And well beyond her bones. Right?
Sure. Yeah,
I mean, that's the thing. It's not just going to be the bone changes that she's going to experience, which is the most amazing thing.
Yeah. No, I'm really excited for her. So I'm glad she got to that point. So then let's dig into HRT. So I know you guys in your book, so I'll hold it up again. I'll hold it up in the intro. So, I loved what you did in the book because you did a great job of talking about some different options. You remained, I would say, arguably relatively bias-free. You were very objective. You talked about the research, and I really appreciate that approach. But I'm sure that there are things that you see that just blow your mind and are super frustrating. So let's just lay the groundwork with what are kind of some of the different approaches that clients will come in on, thinking that they're on quote unquote HRT. So what do you see? What's the gamut?
Really common is the patch and prometrium. We're relatively bias free.
In the book we are, but not in our
right. In the book we are. That's true. These women still have high FSH and a lot of symptoms. And are they really getting the results that most women want, which is to, be in their 70s and 80s and I don't know, God willing, 90s and still have a certain degree of vitality and health.
Yeah.
Right? We're really skeptical of, that being able to do that for them.
Yeah. I mean,
go ahead.
I was going to say, we can start with as much as there are women still who show up on birth control and believe that they're taking HRT. We know pellets, I think all three of us agree on pellets. So pellets, little rice-shaped grains stuck underneath your skin and your hip or your buttock, and they can be one hormone, they can be multiple hormones. So that kind of then leads into, we have issues with, are we administering single hormones? Are we administering cocktails, mixtures of hormones? That's another thing that a lot of women will kind of be given this cornucopia of drugs, hormones, and think that they're on an HRT and gosh, it's not working for me. What should I do? It's like, well, it's impossible to know because you're taking literally everything all at once.
Right.
And then, I think NAMS, North American Menopause Society, probably is starting to become, they've always been the predominant kind of menopause voice in the US, but I think more and more doctors who are starting to at least let their guard down about HRT are willing to go the NAMS route, which is that patch and prometrium. Mm-hmm. Some will do low dose creams of estrogen and with oral progesterone. And so, that's an option too, that's kind of similar to the patch. And then you're seeing more and more injections because of these femtech platforms that have developed through, the miracle of venture capital. And so they're dishing out all sorts of things. We'll see women on vaginal estrogen that think that they are in systemic estrogen. That's a whole nother kind of discussion that needs to be had with the woman to understand where hormones act and how they can act where they're applied. And then, we see everything from different injectables. I think the other thing that women need to understand is each hormone sort of has its own delivery option, right? And most people aren't swallowing their estrogen, but some people still are using pills for estrogen or troches, lozenges for estrogen. Vast majority, though, it's transdermal or injectable. Then we have progesterone. Vast majority, it's oral, which is fine. That's different than swallowing our estrogen. But it could be cream progesterone, right? It could be suppositories. That's becoming more and more common because a lot of women have what's called progesterone intolerance. And so they're finding that rectal administration of progesterone might work. And then there's the testosterone question, right? Like, do all women need it? Should they all be given it? At when? Right out of the gate, et cetera. And testosterone is not FDA approved for women. So you're either getting a compounded low dose concentration cream or you're getting injections. And ladies out there taking the injections, just know that you're usually microdosing, hopefully, or regularly dosing a man's testosterone. And that's a whole nother issue. So, I mean, we see the spectrum, everything. And then you got the forms, but then you also have the delivery timing, right? And so we still have people who take their progesterone every day or take no progesterone because they don't have a uterus. And then we had someone who came to us the other day and said, well, I'm cycling. We're like, great. To me and Maria, and to you, Doug, that means cycling your progesterone on, off every 2 weeks. She was cycling her estrogen. She was taking her estrogen 5 days on, 3 days off. I'm like, that's not even a week. Like, what woman can keep track of that in a calendar? Right.
Right.
Yeah. So there's a whole, literally, you name it. We've seen it. We've seen everything from Maria, Monday, Wednesday, Friday, take this hormone, and the other days take this one. I mean, it's crazy.
Right. I literally just recently saw a prescription for Triest. Imagine that.
Yeah. Get some estrogen in there. Why not?
Yeah.
So from your perspective though, I mean, you've worked with a lot of women, they're all coming in these different things. I'd love to just like check some things off of the list that we don't need to talk about. Like, for example, can we all agree that birth control, once probably across the board, we don't need it, but especially when we're talking about hormone replacement, we should just check that one off the list. This is not an option to consider.
100%.
Okay, great. We don't need to talk about that. Pellets, my concern with pellets, and you're probably similar, where I see a lot of bad experiences. Now, I don't do pellets. I have a telehealth platform, so I can't do it through Zoom. But even if I could, I wouldn't, because I just see the bad experiences, super high levels, differences in absorption rates. Like, it's high, it's low, they feel terrible, especially with testosterone. Bad side effects, women whose hair is falling out, they can't, they're freaking out because they can't get it out. Testosterone's 400. I can't get this thing out of my butt, and my hair is falling out. And so for those reasons, I don't think pellets are a great option either. I've seen them work for some people, but in general, I just like to have more control and flexibility. So we can take those off the list. Let's double click a little bit on the current concept of the patch and prometrium. So for listeners that aren't aware of what these things are, estrogen or estradiol, which is the way that we recommend replacing it, can be delivered topically, can be delivered orally or injected. But in general, again, we said earlier, it's delivered topically. It can either occur through a cream or a patch. Now, the patches are commercially available in various doses. But when you see clients come in, I guess you guys are doing labs. So can you tell me, like, what is your experience with their levels of estradiol and the amount of symptom reduction if they had symptoms in the first place? Like, where are they in that spectrum?
It's a little bit all over the place, with the majority trending towards really low levels. I mean, we find, Kristin and I kind of call them unicorns, where we have women who are able to, Kristin, I know you say that this is often, can be some of their own ovarian production, but I know like of a 60-year-old who's over 100 on the patch, which is just kind of mind blowing, but that's pretty rare. We see women who will like, when I started HRT, my estradiol was 18. Now on the patch, I'm at 26.
Yeah.
Right. And what's scary is a lot of women probably, they don't know because their doctors refuse to test their estradiol levels.
Right. Correct.
And if they had symptoms like vasomotor symptoms, hot flashes, night sweats, tell me if I'm wrong, but pretty consistently, I see that level of 20 to 30 would probably alleviate those symptoms.
Yeah, for the most part. Yeah. Some we hear still have some, but it does. We don't need a lot to suppress hot flashes.
Right. And so then I am on a mission to educate people that in the bone health literature, there is a clear threshold around 60 to 80 picogram per ml of estradiol. But we see quite a bit of variability too, meaning that I do have some patients that are on, what I would consider low dose. Their estradiol levels are probably between 20 and 40, and their bone turnover markers do look better. So I think that some women can see some benefit with lower estradiol levels, but I also see women that aren't seeing benefit at that 60 to 80 and need more.
So I'm one of those.
There you go.
Of those. I did two DEXs. I believe it was a year apart. And I was kind of hanging out in that 60 to 80 level. And my follow-up DEXA actually got slightly worse. I don't know if we have to count the margin of error, but
the other thing too is it's not just bones, right? I mean, I know you're
Right.
using that in the context of yours, but even if you're getting good bone markers, let's say at 60, what's your blood pressure? What are your lipids? Do you
Yeah.
know what your tau protein is? Do you have any plaque accumulation?
Right.
How's your genital urinary, kind of vaginal symptoms? I mean, there's so much more. And I get
Right.
women are so concerned about bones, as we all should be. No one wants to be frail. It's scary to think of losing our independence because of frailty, but we're a body, we're a whole
Right.
system,
Right.
right? And yeah, so we don't
Yeah.
see, I mean, there's nothing worse than seeing a 63-year-old woman who's been on a patch held at 80 picograms per ml who finds out she's got a CAC score of 300. Talk about a woman scorned, or that she doesn't have good bones, right? That
Right.
she's all of a sudden a Z score of minus 2.5 and she's like, what? I have been on HRT. Maria and I
Right.
are like, but not
Right.
all HRT is the same.
Right. Or what does this individual need? And that's where like the individuality comes in, and where we could talk a little bit more about the traditional model of, why HRT fails. So, in my book that you guys have read and graciously wrote a foreword to, the title is like top 10 reasons why HRT is failing you,
Yeah.
because there are so many reasons why it could not be working. And I don't want to dig into that too much because I have too many things to talk to you about. So let's keep going down this pathway, though. So injection, we could dig into a little bit more. Let's just double click a little bit on the vaginal estrogen. So I see this same thing. So much confusion, and I don't know why, because it seems pretty clear to me. But when estradiol is going to be delivered, or any estrogen for that matter, vaginally, are you seeing any systemic absorption whatsoever?
No.
Okay, me neither. And then, so I
It's also too
understand
low
there's,
of a concentration, though, Doug. That's the other
yeah,
thing that so many women don't realize, that what's being given them vaginally is like fractions of what your neighbor who's taking it topically is getting.
right. And not to say that there's not value in it, because there is
Correct.
certainly value in it. But from our perspective, when I talk about even bone health, I say I'm looking at bone health through the lens of health span. So I want to improve all aspects of this entity, but I got a lot of labs on bones. And what's also cool about bones, just a quick thing about bones, is that they leave biomarkers. And you
Right.
mentioned heart and brain earlier, and it's, I agree. Like, we don't know what those thresholds are for heart and brain. I bet
Right.
they're not low, right?
No.
Because the brain's hard to get to, and there's a lot of stuff that goes along with the heart and the cardiovascular system, but they just don't leave good biomarkers. So that's why I think like the bone literature is so compelling, because we can see that there are these thresholds that are at much higher levels than most women have.
Yeah.
So therefore, for me, vaginal estrogen might be used in addition to, but it is not a replacement for HRT if bone is the primary outcome. You mentioned progesterone intolerance and people going to suppositories, and I'd actually like to learn more about that. But let's talk a little bit about the oral progesterone intolerance, because this is something that I didn't see for a long time, and then I just started seeing it all over the place. So I don't know what happened, if my population changed or what. But what do you do when someone says, I just can't tolerate, even like 50 milligrams of micronized progesterone? Like, is there anything else to do other than switching to another route, or are there some other things you can do?
We have to check their estradiol level for sure. Yeah, that's
Yes.
number one. Mm-hmm.
So walk me through that then. So if a woman is on both, assuming that she's on both when she comes into your practice, what do you see in relation to the estradiol level? What are the symptoms?
Well, usually she's
it's often low. Yeah.
Usually her estrogen's low. I mean, what women don't understand is it's very typical of US medical medicine, right? We silo. And there's a huge push right now that all women need, and the only thing women need is progesterone. That there's this kind of push that this is now going to solve us. And so women are being given increasingly higher doses of progesterone. We had a woman who was like an 800 milligrams. For those who are unfamiliar, progesterone has a very sedating effect. And 800 milligrams, God bless her, I don't know how she was scraping herself out of bed every morning. Yeah. But that system, that relationship between our hormones is so key, because estradiol needs to reach a certain peak in order to create progesterone receptors. This is a monthly sort of mechanism that happens. And so a lot of times women are being underdosed on their estradiol they're therefore not having enough receptors for their progesterone. Then they're being given progesterone, and some doctors will say, well, you must not have enough if it's not working for you. And so they keep giving them more and more progesterone. And so you're pouring this progesterone into a vessel that has no ability to utilize it. And progesterone can be, anxiety driving, even though it can be anxiety solving. It depends on, is the body ready for it? Does it have good receptors, et cetera? Even in those instances, though, Maria and I have seen, and both personally experienced, that sometimes we just don't like how we feel on progesterone. There's women who they feel just kind of cranky. We're ready to kind of rip someone's eyes out. We might get some sleep benefits, but to be honest, most women don't appreciate that estrogen is actually your bigger sleep improver in terms of sleep architecture and quality. So again, if sleep is the problem, might not just be progesterone, or might not be it at all. And then there's kind of this fluffiness. And I don't, as a guy, might not understand that, but for women, like, we're very attuned to when we just sort of start to feel our body change. We all probably experienced it during our natural cycle, but then when we start taking HRT, we're very keyed into like, whoa, the scale just went up 3 pounds, or my jeans are tight all of a sudden overnight. What's going on? It's frequently sort of this water retention, extra weight gain, et cetera, that can happen during the progesterone cycle. Again, it happened naturally. Most of us kind of learn to deal with it. But when we've been without hormones for a while, it can take the body time to acclimate again. It can take the time to build receptors again. And it may not be ultimately the same experience as when you were making it naturally.
Yeah. Do you see GI intolerance, people that complain of GI symptoms with oral progesterone? I've seen that recently too.
Yeah. Like GERD, really? Like heartburn?
Yeah, I've heard GERD, I've heard, constipation, I've heard diarrhea, and I've heard constipation actually a lot.
Well, I mean, and again, if women had paid attention, and I'm not, blaming anyone, Maria and I didn't realize the kind of implications of it when we were younger too. But during our premenopausal years, when we had our luteal phase, that second half of the cycle with progesterone, it's very common to have a slowing of the bowels, slowing of digestion. Progesterone impacts the parietal cells in the stomach. It does change our bowel motility during those 2 weeks. And then what really honestly happens, the progesterone falls off, we'd get our cycle, and a lot of women would have loose stools right around their period, right? Yeah. None of us were blaming progesterone at the time. We're just thinking it's our period. Right. And so, then when we start this HRT and we see these kind of digestive changes, women are like, whoa, most of us have been doing a lot of work on our gut. Why is this happening? It's a natural side effect of progesterone to have slower motility, reduced digestion, and therefore maybe a little constipation or change in bowels. Yeah. Marie and I say, so support it with digestive enzymes. Be more mindful of your fiber intake, either less or more, depending on what works for you during that time. Like, there are ways to sort of hack around the impact of progesterone on the gut.
Yeah. Oh, that's really helpful. I appreciate that insight. So then for women that say can't tolerate oral progesterone, let's say we can't get them there, when is switching to a topical reasonable? And I have my like doctor concerns about that. But what do you see women doing? Are they switching to topical? And then what are your thoughts on that?
Yeah, I mean, it has different effects. So I would say they probably need to give, I would say oral, probably give it like 6 months at least.
Yeah.
Before they switch.
Yeah. And that's assuming they're working on that estradiol level simultaneously.
Sure. Yeah.
And I'm sure your doctor concerns are that there's conflicting information as to whether or not transdermal progesterone gives enough uterine protection. And that tends to be what most doctors, tends to be what most of them. We'll share with you some studies that show actually it does give adequate protection.
I think the challenge is that you can't measure it in blood. So when you're using topical, we don't know, but we've talked about this internally too a lot recently. And, I think our default is really, we should be measuring probably endometrial thickness, probably no matter what your style of HRT is. We'll get into that in a minute. Because we do see, we've seen it in women who are on static dosing, taking the same dose every day, that they still can develop endometrial hyperplasia. And I think we're partly to blame for that. I probably shouldn't say that, but we're partly to blame for that because we are pushing estradiol levels up, right? We want people to get to that threshold of 60 to 80, and not all women can tolerate a lot of oral progesterone. So really, we should probably know clinically, is this happening? So I think this idea that like, well, we shouldn't use topical because we can't measure it. Well, you can measure the outcome that you're actually worried about.
Well, and are
Right.
women getting a shed at all? I mean, that's the other thing. We got to get into the whole continuous cyclic discussion, because the
Right. Yeah.
vast majority of women are in continuous progesterone. They're not going to get a withdrawal shed. And then they go in and they're like, oh my gosh, my stripe is 9 millimeters. And their doctor's like, stop your HRT. This could be cancer,
Right.
and that's the worst possible thing that could happen because it has nothing to do with cancer.
Yeah. And so let's talk about that, because I love this like the term of physiologic ceiling of what's called static HRT. So we'll define that. So when I was trained to use HRT, as is true with I think every doctor, no matter their background, we have over the last 20 years just accepted that for postmenopausal women, we use the same dose every day.
Mm-hmm.
Maybe, in the health span space, you might get like take Sundays off, or like maybe 1 week off a month. But generally it's like there's some kind of window, but most women are on static dosing, same dose every day. That is not how it used to be.
No.
Before the, the early 2000s with the DHEA and other studies that came out, when I started looking at research on this, it blew my mind that most protocols in most big studies were on some kind of rhythmic protocol, meaning that they were cycling progesterone, and they may have even ramped up and ramped down estradiol. Yeah. And so when I saw this, I really started digging into it. And I can tell you from the bone health perspective, every study with a rhythmic approach had better outcomes than static approaches. Yep. And it just blew my mind. And so this has really pushed us to get into this idea of like, well, what are our options here, and how can we do this in a manner that is going to most effectively serve people? But before we get into that, I wanted to talk about the physiologic ceiling and what that means. So for me, if I'm driving women's estradiol level up to 60 to 80, there is a threshold at which they can't tolerate more progesterone. And that's what was described to me as the physiologic ceiling. We just can't give them more estradiol without then risking the endometrium getting bigger and having the potential. I mean, there is a potential for endometrial cancer, but essentially they're just developing a thickened endometrium, and they might have breakthrough bleeding. So we can't get them necessarily high enough without switching to a rhythmic approach. Mm-hmm. So again, this was new to me over the last year, and we now have some patients who are doing rhythmic approach, and we will talk about this when we talk about PEMA bioidentical later. But what has been your experience as you were both on a static approach, and then now that you're in this space of utilizing rhythmic hormone replacement therapy? What have the changes been that you've seen?
Well, gee, I started with Biased about 12 or 13 years ago, and I was like, wow, is this doing anything? I didn't even have like any symptom relief. And now I was on static estradiol and progesterone, and just, I mean, any of the benefits that I felt initially from being on HRT, because we often call those newbie wins, right? Mm-hmm. Whether it's the patch or even a pellet, just newbie wins, they just went away. Like that whole kind of sleep benefit from static progesterone just went away after a few months. So yeah, and then I just didn't really feel mood or just vitality benefits until I switched to physiologic rhythmic, and basically, quite frankly, even just a physiologic amount of the hormones, and then done rhythmically and cyclically. Yeah, much better.
And Kristin, can you like expand on that a little bit? Like the definition for you guys, what is physiologic, and then when we say physiologic levels, what are we saying?
Yeah, so physiologic is just referring to, the level at which your body essentially used to produce, right? So we're kind of mimicking the body's actions prior to menopause. And in terms of what level that would be, if you look at a chart of a woman's production, and there's studies that have looked at this, they show the high and the low of the average woman, and they kind of make this beautiful rhythmic graph out of it. We know that estrogen production is the lowest in the second half of the cycle. So that's our luteal phase. And if you look at kind of what the average is for the average woman, what her levels are during the luteal phase, it's about 150, for some maybe 100, 150. So, that to us would be the optimal minimum that you would give a woman. And again, the package insert, even in the 0.1 milligram patch, which is the highest dose commercially available, says it's not going to achieve anything above, I think, 80 or 90 picograms per ml. So we're well below the threshold, right? We're almost half. That is a concern to us, is that, again, why are we keeping women in sort of this suspended state of hormone decline or hormone deficiency? If you were 30, let's say, and you were walking around with a daily level of 80 picograms per ml of estradiol, you would have significant side effects from that. You would likely be getting the attention of physicians, and they would want to be supplementing your estradiol levels. So why we've suddenly come to believing that that's sufficient for women who are postmenopausal, Maria and I are still trying to unpack that. Like there's nothing to explain why we will take a 35-year-old and ensure she has optimal physiologic levels of hormones, but we're not going to do the same for a woman in menopause. And it has nothing to do with fertility and menstruation. The reason why they're concerned about the 35-year-old is bones, it's brain, it's heart health, it's all of these things. So if we know that, and no one argues that, nobody argues premenopausal women's hormone levels should not be, 100 picograms or 150, and yet everyone argues about it when it comes to postmenopausal women. Maria and I are not feminists. We're not, part of this whole screw the patriarchy. We love men. We love, ourselves and being women and whatever. And we're happy with, the lives that we have. But God damn it, that's patriarchal, is telling women, you, because you're older, don't deserve the same vitality and health benefits at levels that we would be concerned about your 35-year-old daughter at.
Yeah, well, that's such a great segue into what I want to talk about next. But also, I did the same thing when I looked at the literature and the recommendations for HRT for women, like post-surgical menopause women in their 30s, 40s. The recommendation is totally different. Yeah. And that was my sort of the big question mark in my head was like, well, why is a woman at 50 getting different recommendations who goes through natural menopause? And I know that there's some argument to say, oh, well, there's still some, there's some natural hormone production. Yeah, but not very much. And so I still haven't found very many doctors who can explain that. Yeah. I like to ask that question because they look at me like I'm crazy. But the feedback I get from patients and clients is this, which is, well, in menopause, this is natural and this is what my body is supposed to do. And therefore, using a rhythmic or physiologic approach that's going to especially, continue my menstrual cycle is not what I want to do. And that's just not natural. So how do you deal with that? Because I'm sure you've heard that too.
Okay. Natural is nothing. So, you want to be really natural, just do nothing.
Right. And if you were a diabetic, let's say type 1 diabetic, it's natural for you that your pancreas produces no insulin. We're not going to let that be the situation that you're going to live in, right? Yeah. There's no reason why we continue to tell women, natural is the optimal, because it's not optimal. Now, I will also push back and say, natural for how long? Because
that's true.
In the early 1900s, we weren't outliving our menopausal years by 3 decades the way we are now. Right. And that is something that these women are missing. It's like, not only that, but back in the early 1900s and actually through 1950, hormone replacement for postmenopausal women was considered preventative medicine. Mm-hmm. And it was done as a standard of care. And now we've had, this kind of 75-year blur, thanks to pharmaceutical intervention and, corrupted science and everything else, that now we've got women believing that it's natural to go without hormones. It never was natural. People like to talk about, let's say the paleo diet or what foods are, primally recognized by the body, and that we haven't had thousands of years to get accustomed to canola oil. No one seems to argue that. But Maria and I are like, okay, well, if it's only been 75 to 100 years that we actually started living beyond our menopause, why is it suddenly natural?
Well, and Kristin, I thought you were also going to say this, when you said it's natural, but for how long? So the same people that at 50 or 55 are saying, well, I want to do this naturally, are they going to say that it's 65 or 75 when they need a statin or a beta blocker or metformin or,
Bisphosphonate, all of the above.
Right.
yeah.
They need me to
Are
fix
they
their hip
still going to
flexor.
be natural?
Right.
Yeah.
Probably
I
not.
mean, and if we want to say natural, let's define natural of 70. It's, I think, an average of 12 prescription medications.
Yeah.
How's that natural?
And I look at this through my patient population, and I see so much regret in women who are, they're 20 years out or they're 25 years out. And then I have to have that conversation and say, look, your cardiovascular risk is pretty high.
Yeah.
Like, I'm actually not comfortable prescribing for you at this point because I'm not certain that it's not going to provoke some kind of an event.
Right.
And so there is a window. It's not nearly as small as a lot of doctors will say it is, but there is a window because living for, 2 to 3 decades without hormones will have an impact. There's no way to hide from that. And then I also look at it and say, because I get this question all the time, like, but it's not natural. And I say, look, what's natural is to lose your hormones. What's natural is to lose bone steadily, consistently, lose muscle mass, lose cognitive function, develop heart disease, and die. And that's totally fine if you want to go through that in a natural way. But if you want to prevent that, these are the tools that we have available to us. And,
Right.
And there generally isn't a comeback after that because we all want a better life, like a lifespan and a health span. We all want to live better for longer.
It's natural to lose your vision. You're not going to go get glasses. It's natural, women, come on, we're all concerned about our aesthetic and our physical appearance. It's natural. For me, I turned naturally gray at 17. That's when I started going gray. And by the time I had my second son in my mid 20s, I was fully gray. Okay. So that's my natural. That's what I got to stick with. I mean, it's kind of become a virtue signal. I hate to say it, to claim that you're going to go into menopause without hormones because it's more natural. It's honestly, it's very naive and at worst ignorant.
Yeah.
Well, I appreciate your insight on that. I just want to do one last topic and then we'll wrap this up because I do try to keep these short, but we could talk for hours and hours. When it comes to labs, I get this question a lot. Women will say, like, what labs do I need? What labs do I need? And we have we have a whole thing around this with Pema Bioidentical, helping people to get labs. But what do you think are the most important for people listening so that they could get a sense of what's happening? And then also, how do you help them to get them?
Well, what age are they?
Right.
Let's say they're between 52 and 64 and they have gone through menopause.
Easy.
Oh, are they on HRT?
Sure. Well, let's give an example of both. I mean, I think we know the answer if they're not on HRT, but let's give an example of both.
I mean, estradiol, like let's see what your level is, and FSH. That's a definite, progesterone maybe once a year. I don't think it's as important to test that, but
and are you using, do you like to see FSH drop to a specific level? Is that what you're kind of measuring estradiol from?
I'm okay with the step down approach. We don't want to see it above 25 if you're on HRT. Then it's like, why? just you'll probably be the same off HRT. They're in kind of a menopausal state at that point with an FSH of over 25, and then 10 is really good. And I guess 5 is the golden ticket.
Yeah. Okay. Great. I know Dr. Moscati she's pushing me to use that more effectively. It's not a tool that we're currently using, but definitely one that we're going to consider.
Can I just say one thing, Doug, on that is that Maria is a perfect example of someone who she's been on gold standard HRT for many, many years. She was struggling persistently with a back problem. And her doctor wasn't always necessarily looking at FSH. And so Maria pulled it. And our FSH, which for those listening, it's a brain hormone, right? So it's our brain sort of surveilling the landscape and deciding, do I like what I see? And for Maria, it was higher than she expected. And it was kind of this, she's not messing herself up in the gym. She's not doing something wrong on her daily basis. It's not because she and I sit half the day talking to clients. It's truly that her estradiol, even though the level was at a good level and acceptable, to her body, it was different. It was too low. And as soon as Maria was able to take FSH and use that to persuade her doctor to dose her higher, what happened, Maria?
I no back pain at all. So
So the prevailing thing is either you look at labs or you talk to the woman and don't look at labs. And Maria and I would say you have to do both. You have to look at labs and you have to talk to the woman, because we as women, we will find a way to make good enough good.
I mean,
And that's not
I did
necessarily
that and I know better.
Yeah.
I was like, oh, and I never occurred to me that could be my estrogen. Never mind the fact that when I was in estrogen decline in my 40s, I had all sorts of, shoulder and elbow issues, but silly me, didn't do that.
Yeah, it's definitely on our radar when we have people complaining of musculoskeletal pain. It's got to be a part of the picture for sure.
Yeah.
So I wanted to touch on androgens for a second, and this is something it's been changing in our practice as we've gone through this path of testosterone is awesome. Many people feel better on it, but what we're finding is that it's not as well tolerated as I would hope, or now I expect. So what's your experience with testosterone for the women that you've worked with? And then also if you could contrast that with DHEA or pregnenolone or whatever precursor you want to talk about.
Well, we get women to do estradiol and progesterone first, get that kind of settled, established, and locked in. And then if they feel like they could use some testosterone based on, maybe I just want to tweak things, maybe I want to be able to build a little bit more muscle, have a little bit more motivation, then we sure recommend that they do testosterone. What we see that is troubling is that there's just this grand push for testosterone, over testosteronizing women. I made up a word, but it's just like women are just going. I see women with levels like literally higher than my 23-year-old sons, 25-year-old sons. They've got like a free testosterone level of 20 to 30.
Yeah, that's high.
Yeah. I think one thing that a lot of physicians don't fully appreciate is that testosterone and estradiol at the receptor share a cell wall. And because of that shared cell wall, if we start dosing testosterone before we've optimized our estradiol, we can make a woman's on-ramp to optimizing her hormones with HRT more difficult, because that testosterone can block up to a third of the estradiol at the receptor. So the woman's not going to get the benefit that she's expecting from HRT, and then she'll blame the HRT, or her physician will respond with, well, let's just do more testosterone.
Yeah. Mm-hmm. Yeah. And then from a side effect perspective, are you seeing significant side effects from the testosterone?
Hair loss is huge, but this voice box change has become, because I think there's so much of these femtech platforms who are dosing male testosterone vials to women to inject. That is something that most of us don't identify until it's already happened, right? Mm-hmm. We're not aware of our voice changing, and then all of a sudden it's low. And the sad thing is we can eventually get hair back. We can do surgery on clitorises that become enlarged like penises, horrifying to think, but at least there's a fix for it. There's no fix for the voice box change. And it's really, really sad. I think a lot of women out there are going to say, but I need it for libido. And Maria and I are going to call BS on that over and over and over again, because the only time testosterone really improves women's libido is when it's at super physiologic doses, at super high doses. Estrogen is what makes a woman really have a great libido. And so again, if you're kind of prioritizing your HRT for health optimization, get that estradiol dialed in. You will be shocked at how at certain levels you're getting the sleep benefits that you thought you needed from progesterone. You're getting the libido that you thought you needed from testosterone. There's so much to be said for estrogen being overlooked for these basic complaints of a lot of women.
Yeah. And then are you seeing with precursors like DHEA or pregnenolone, are you seeing women that can use these effectively at giving, they're not going to double, triple, quadruple their testosterone levels, but can they get enough?
I've not seen that actually. No, I haven't.
DHEA can help for vitality, for energy, mood.
Well, for that, but I don't necessarily see it funding or going into having better, say, estrogen and testosterone levels. I don't know if that's what you were referring to.
Yeah, that's what I mean. Is that so my thought is, well, if the adrenal glands are still working and a woman's working on lifestyle and stress mitigation and getting good sleep, if they're not making cortisol at a really high rate, then they should be able to make DHEA, which would convert. And there's literature to support that DHEA supplementation can increase testosterone levels in women. It's not profound. It's
No.
not like
Right.
replacement.
Yeah.
Correct.
But my goal now, especially because we are optimizing estradiol and progesterone first, is to give them some androgen support and then see
Yeah.
where they end up.
Yeah.
And so I guess the good follow-up question to that would be, for women that you feel that are actually optimized from an estradiol and progesterone perspective, how many of them actually need testosterone?
I mean,
25 to
yeah, the
50.
research says 25%.
Yeah.
Yeah.
But I'm someone who I did not have probably great adrenals coming into my HRT journey. I also had a lot of receptor problems because of decades of exposure to a synthetic IUD. And I was struggling with that energy piece. And so my provider said, look, I can give you DHEA without interfering with your estrogen. And so I think that's where, if a woman's really struggling with kind of that mood, vitality, energy thing, DHEA can be hugely helpful there. It does decline naturally as women age. I mean, that, even those of us with the best adrenals, you're going to see a slowing of production. It has benefits. I mean, we know that DHEA has other physiologic benefits in the body. So to us, it's like that might be all a woman needs to sort of put the icing on the cake of a really good HRT regimen without necessarily needing testosterone. I mean, I just did a trial and I literally stopped my testosterone for 6 straight months. And I'm calling Maria and I'm like, I don't notice any change.
Same.
And I think that's a really big, thing, is like how much of it is a placebo effect for women in the beginning, that this testosterone just made them feel amazing, assuming it was at a low, appropriate for women dose. I don't know how much of us really, really, really need it. And
So, Kristin, I'm at the kind of on the same,
experiment
trajectory
path.
as you. And we didn't even plan it, but I just stopped my testosterone because I was like, oh, I just need to kind of figure out this estrogen thing. And I've been on DHEA. I notice zero change for the better or for worse. And quite frankly, every so often I am a little tempted to say, oh, well, maybe I'll grab some of my husband's testosterone, which is like 10 times the concentration of mine. And I'm like, no, I feel pretty darn good. And I don't want negative side effects.
Yeah.
Yeah.
But I strength train a lot. I didn't notice any change in my muscle tone from dropping my testosterone for 6 months. So, there's a certain amount of cheat code that I think a lot of women are expecting from testosterone.
Mm-hmm.
Ladies, you're not going to throw testosterone and suddenly lean out and get muscle definition. You got to put the work in, follow Dr. Doug for that. So it's frustrating that, because estradiol is so often associated with cancer risk and we have so many doctors who are afraid of it, suddenly testosterone's become the new shiny object for a lot of them who want to appear pro HRT. And they're like, women need testosterone. It's the most abundant, hormone in the female body. There's a lot of gray area in that in terms of what they're really saying and what we're really measuring and what testosterone's actually doing. How many women realize that our estradiol comes from testosterone, right? That's a conversion process that happens. So it's frustrating because we are starting to masculinize women with overdoing testosterone. And for the young ones, they seem to be the more vocal proponents and beggars for testosterone right now. Ladies, start freaking eating enough, get off your damn phones before bed and work on your adrenal health, because the vast, vast, vast majority of these 30 somethings and early 40 somethings who swear testosterone changed their life, no, you need to go change your life. Your life, that's a sign right then. If you are low testosterone in your 30s and 40s, you have a lot of work to do.
Yeah. Well, and so I can actually echo this. So I've been on testosterone. So now we're going to switch to men's hormones. So I've been on testosterone off and on for the last 3 years because I've just failed to be able to maintain it because I've been building companies and have 3 young kids and not focusing on myself. Let's call it what it is. But on testosterone, I did notice not side effects of hair loss, although I don't have a lot to begin with. But what I did notice is my iron levels were through the roof.
Oh,
and
yep.
so
We were going to bring that up, as well as the polycythemia. We've definitely seen that.
yeah, I mean, polycythemia, I think we see that. We definitely see elevated hematocrit and hemoglobin. But for me, I have this deep interest in iron and iron metabolism and oxidative stress as a result of that. And I mean, like through the roof, like ferritin's like 300, 400, and I'm like, I can't keep this up. Like this isn't good. And so I'm actually off of it now for several months and I feel great.
Yeah.
So it's just really interesting that like I have been using it as a crutch and I've been using it as a cheat code. But off of it, I am more obligated now to make sure that I'm getting to bed on time. I wake up, I have my morning routine, I'm doing my meditation. Like I'm looking at my days and looking at my schedule and saying like, is this realistic? And then just trying to really dial that in. And I got to tell you, I feel so much better off of it than I did on it.
Well, and I got to put a plug in there because we work a lot of times with males who are the spouses of our original clients. And we had a guy come in who, it's not just the oxidative stress of poor iron, right? It's iron dysregulation can affect insulin levels, can affect LDL oxidation, can affect plaque accumulation. And this guy was in his 30s, okay? And he was a go-getter like you. He's actually also a physician. Way too many, thumbs and different pies, and young family, and just go, go, go all the time. And sort of wore it as a badge of honor. He was taking excessive amounts of testosterone. I think, Maria, his level was like 2,000, I want to say was his total. His iron was so alarming that we were like, you need to go tomorrow to donate blood and deal with this. But then we recommended that he go get a CAC score. And Doug, he was needing a stent bypass. His carotid artery plaque was or coronary artery plaque, and then he had a CIMT done, was so bad the guy was a ticking time bomb. Was this 100% related to overdosing testosterone? Probably not. Stress, we know, is a huge driver of those things, but people don't understand that it's not just polycythemia and iron dysregulation. Those two things then affect everything. Again, body is a system, right? And how tragic that someone who just wants to jack up a little bit might be actually hastening themselves into an early grave.
Yeah. And we do look, with my practice, because we look at everything, quote unquote, through the lens of health span. Like we don't want to improve muscle mass at the risk of cardiovascular health.
Right.
And now, the recent studies on testosterone in men looking at cardiovascular health were pretty convincing, but the studies were not very good. The Traverse studies used low doses. They barely really nudged their testosterone, and the findings weren't nil. It just wasn't statistically significant.
Right.
And it wasn't nearly long enough. And so I'm not convinced that we really know the answer to that, but I don't think it's the testosterone, it's the side effects. And I don't see the iron dysregulation globally, but I've seen it in some women, and I've definitely seen it in men, and I've seen it in myself. So I think it's important that people know that. Yeah. All right. Well, I think we've gone long enough. We're almost at an hour, and I said we were going to go for 30 minutes. So I think let's wrap this up here. Maybe we need to do this again sometime, but I hope this was helpful for those that are listening to it. And I want to thank you guys again so much for your time and for all your efforts in the field of hormone replacement, because I think it's really valuable.
Pleasure. Thanks for having us.
All right, so I hope you enjoyed that interview with Kristin and Maria. They are so fun to talk to. I love their clinical experience. If you haven't read their book yet or ordered their book yet, depending on when you watch this video or listen to this podcast, The Great Menopause Myth will be available either soon or after this video airs. And we have links for how to get that in the description on YouTube and on the podcast page. If you are looking for more information about hormone replacement therapy and you want to join our masterclass, we are running a masterclass talking about these concepts and more for hormone replacement therapy, not only for women with osteoporosis, but also for any woman who is looking to optimize their hormone replacement therapy. I recently wrote a book called The Top 10 Reasons Why Your Hormones Are Failing You. And we go through all of those in this masterclass and then talk about how to potentially get your labs drawn, how to learn what your levels are, and how to really optimize hormones. So if you're interested in that, link for that in the description on YouTube as well. If you're listening to this on a podcast or just want to know more information about our company for hormone replacement therapy, go to PEMA bioidentical.com. That's PEMA bioidentical.com. And you can learn all about that company there.